Hello, everyone, and welcome back to another edition of IPC in Action, our in-house podcast. So my name's Jen. I'm one of the senior infection control nurses in the Trust, and today I'm joined by our special guest, Nabeela. Nabeela, would you like to introduce yourself and let us know what your role is?
Hi everyone, my name's Nabeela. I'm the endocrine specialist pharmacist, and I'm here to talk about some of the audit work that I've done.
Amazing. So, yeah, we're the sort of theme and topic of this podcast episode is around sampling, obtaining those specimens that we need to make sure that we are appropriately treating our patients with the right drug at the right time. So what was the audit that you carried out, Nabeela?
So the audit that I looked at was more focused on urine sampling, and it was more specific to when IV antibiotics were being prescribed. So in this case, it was gentamicin or temacillin. But we are looking at sort of extrapolating this into general urine sampling and the habits that we have around the hospital at the moment. So the reason why I did this audit is specifically because we have anecdotal evidence that the sampling wasn't being done as often as it should be. And obviously there's quite severe potential repercussions to this with antimicrobial resistance on the rise and patients' infections potentially getting worse, leading to things like sepsis. We do have a policy that covers this, and we were trying to see if there was compliance with the policy.
That's really interesting, yeah. And I mean, I think people can be assuming quite a lot of the time. There can be some pretty bold assumptions made that, oh, well, they're on antibiotics, but they might not be the right antibiotics, and they might not actually be treating that infection. So what were the things that you did find in your audit?
So what I did in terms of this audit is I looked at around 250 patients across both sites of the hospital. And I had some inclusion and exclusion criteria. So one of the exclusion criteria was if they were on antibiotics for anything else at the same time, they weren't counted in this. So this is very specifically patients who had UTI, urosepsis, or pyelonephritis. And we looked at whether a urine sample was taken either before the first dose of antibiotic was given or within 24 hours after. And that's kind of what we're looking at as the gold standard, really. So what I found was after analysing these 40 patients, was that only 15 of them actually had the sample taken before the first dose of antibiotic was given.
Okay.
And actually that is nice guidance to say that we should be doing it prior to that. Because once they've had a dose of antibiotics, that can then affect the results that we get.
Because it would select out some organisms.
Exactly.
Yeah.
And out of those...
To double check, does that mean that if some organisms are selected out, would that then mean that what's cultured on the urine sample might not be a true reflection of what's actually growing?
Absolutely. For some patients who, say, for example, have a dose of IV gentamicin, they may only need that one stat dose, and that can then potentially cure that infection. So if we've then given them that dose and then taken a culture 24, 48 hours later, it won't show anything.
Yeah.
When the reality is they did actually have an infection.
Yeah.
And the other thing with that is we're not really looking at their sensitivities. So gentamicin is quite a broad spectrum antibiotic. And really, maybe we could have treated that with something like nitrofurantoin. And we won't know now because there's no organism grown from that patient's culture. And if we keep doing this over and over, there's going to be widespread resistance to these really sort of broad spectrum antibiotics. And that's very concerning.
Yeah. And although it's broad spectrum, it's quite a high level antibiotic. So we don't want to be going in with our...
No, it's the big guns, really.
Yeah.
And if you start there, then you have very few things you can step up to after that.
Yeah, and we're just going to end up shooting ourselves in the foot with then not being able to treat people with really quite simple, what currently now and in the past have been entirely treatable infections that one day will not be treatable.
Absolutely. There are already patients out there who have drug-resistant UTIs, and it's quite difficult to treat. We're having to use multiple agents at the same time, and that's something we definitely want to avoid.
Yeah, for sure. And just if you're looking in your medical notes, those like multi-drug-resistant organisms, they can sometimes be written as the acronyms of like VRE or GRE. GRE is much more commonly seen now, and it's that glycopeptide-resistant enterococcus. And you can quite often see that maybe on your handover sheet or maybe in the medical notes and think, I'm not 100% sure what that is, because you'll just quite often get these acronyms repeated, and this patient requires isolation because of a GRE. So what Nabeela's just been talking about is a perfect illustration of why we want to ensure that we're taking samples and not going straight for the big guns of antimicrobials, because we need those big guns for the future.
So following on from those results, so like I said, only 15 people had the sample taken before the first dose. About 10 of those 40 had it after the first dose was given, so within 24 hours of that dose being given. And about 4 patients had a sample requested but never taken.
Okay.
And what we did find is that a couple of patients had a sample from the previous week. So, for example, it might have been done in the community by their GP, which that would have been counted as, yes, you've covered that.
That would be acceptable.
That would be acceptable.
Is there a cut-off time?
We'd say within a week, because
Okay.
the reality is if they've had antibiotics and then we don't know if it's reoccurred or it was just never fully treated in the first place. So we put that cut-off at about a week time period.
That's helpful. So if they've submitted a urine sample to their GP, or, you know, they've had one collected from a care home or community hospital, we could then count that with some other clinical information.
Yes, you need to use your clinical judgment. Yeah.
Within 7 days. So that's a helpful sort of time frame. I didn't know that. That's helpful to know.
Yeah, so we had that as a cut-off, and then because that could at least guide the antibiotic therapy at that point. That's not to say you shouldn't do another sample, because things may have changed. It might have been caused by a different organism at this point. We wouldn't be able to say without reculturing the patient. What I did find was overall 32.5% of patients had no urine sample collected at any relevant time whatsoever. So they've had their inpatient stay, had this working diagnosis, had antibiotics, IV antibiotics no less, but never a sample done.
Oh, wow. 32.5 patients.
Yeah, so that was quite concerning, really, and it shows that we're significantly non-compliant with our current protocols.
Yeah.
And that's something that we really need to work on improving.
Absolutely. So what can we do to improve that?
So I did speak to a range of doctors and nurses to try and find out what's going on in the background, why are we not compliant with these protocols. And some of it came down to sort of using the system that we have, the EPR system, and sort of knowledge and education around how to use it.
And maybe what to request.
What to request specifically
as well. There's so many tests available, it's sometimes a bit confusing for what to request.
Absolutely. So there were doctors and nurses both saying that they weren't sure how to request or where to look that a patient had that sample requested. There were some communication issues. So some doctors mentioned they had requested it on EPR, but maybe not verbally communicated that to the relevant nurse. Nurses also said that sometimes it was in the doctor's ward round plan, but then wasn't followed up either verbally or actual test ordering. A couple of doctors did actually mention that they felt like the diagnosis was very clear. They knew that there was a plan in place, so a sample wasn't really relevant or needed at that point. And obviously, in some cases, it was perfectly valid. They were unable to take a sample, so patients with delirium, aggression, that kind of thing.
Yeah. There will be some of those instances where
Yeah.
it's just not possible, but we need to make those the exception.
Well,
not
this
the
is
rule.
it. So obviously, in an ideal world, we'd have 100%
Yeah.
compliance, but we dropped our rate to 85% to account for this.
Yeah.
But despite that, we're not even meeting the 85% at this time. So in terms of what we can do, so I reported back my findings to the pharmacy department and the microbiology department. And we've looked at what we can do. So in terms of pharmacy department, pharmacists are being encouraged wherever they see antibiotics being prescribed to look at the indication and see if a relevant sample was taken. Obviously, this is not really the role of the pharmacist, but it's to try and encourage holistic patient care from all angles. In terms of microbiology, I believe there's an ongoing project in looking into sampling in general and how we're falling short across the hospital. So we've started some work in the background on creating a UTI bundle. So similar to the sepsis bundle, a UTI bundle, because we feel that it's just as important. If a patient has come to hospital because of a UTI, it's quite severe.
Absolutely.
It's already at the point where they're quite unwell and that they can deteriorate very quickly and go into things like urosepsis or pyelonephritis. So we're looking at a 3-stage bundle. So when the patient presents either to A&E or AMU via GP referral, what to do then? And then what happens once you actually have a confirmed diagnosis and cultures back, what to do then? And prior to discharge, how they should have safety netting and whether they need follow-up, say, for example, with urology, depending on whether it's a recurring event. So that is a big piece of work that will take a while, but we are working on it at the minute. I'm hoping this podcast will reach a few people.
Absolutely.
And sort of get the wheels going on improving that compliance.
Are you looking for help with that?
Absolutely. If anyone has any great acronyms, ideas, things they think absolutely need to be included in the UTI bundle, I'd absolutely love to hear from them. It's important that we get it right because it is going to be a big culture change and a change in the way that we work. So it's better that we get it right to start with.
Absolutely. That sounds like a really needed and very
Definitely.
helpful project. And I mean, obviously, Nabeela's work has been predominantly around urine sampling, but what we're just also wanting to push is obtaining those specimens in other areas as well, such as making sure that if a patient's presenting with diarrhea, for instance, that we are sending those stool samples as promptly as possible, just so that we can ensure that patients are being treated at the right time, as quickly as possible with the right treatment, whether or not that is antimicrobials that are required or whether or not it's more sort of symptom management with fluid resuscitation and so on. Wound swabs are another area where we need to make sure that we know what we're working with. A lot of the time when patients are presenting with, for instance, chronic leg ulcers and things like that, we just need to make sure that when those dressings are taken down, take a quick swab of the wound. Another thing that's just really important to highlight with wound swabbing is just to make sure it's really obvious what you're swabbing, like what the site is, because quite often it might just say like left leg, for instance. And although that's very clear to perhaps staff on the ward or in the department what that is, it's a lot less clear for the lab staff and for the other people that end up looking at that result. So it's just about being really, really clear exactly what you are swabbing when you're taking that specimen. When you're looking at collecting urine samples, we just also wanted to highlight the importance of collecting them into a sterile container. So taking that sample directly from a commode liner, one of the sort of the pulp product, commode liners or bedpan, it will very likely be contaminated. Those commode liners are stored in the sluice. They are stored in a dirty area, and this will mess with the culturing of the urine sample. So we just want to make sure they're being collected into a sterile galley pot. And you can just put those in the commode liner and hopefully some of the urine would then go into that container and you can just collect it directly from there. It would just make sure that we're singling out exactly what is causing the patient's infection. Equally, they can go into a bedpan liner, just to make sure that we're collecting as aseptic a sample as possible. One final point to mention about stool sampling is it doesn't matter if a stool is mixed with urine. It doesn't matter if it's in a pad. It doesn't matter if it's on the floor. We just need that sample taken. It's not the same as urine that needs to be collected as aseptically as possible. Stools can be collected, the sample can be taken even if it's mixed with urine, mixed with blood, it doesn't matter. We just need that specimen sent to the lab, please. I think we've done a very whistle-stop tour of the importance of specimen sampling, and the biggest reason we're wanting to do it is to improve those outcomes for our patients, to make sure that they're receiving as few antimicrobials as possible, to improve their outcomes. It will also reduce their time in hospital and reduce their risk of developing further HCAIs. If we're giving everybody sort of broad spectrum antibiotics, we're going to wipe out all of that healthy gut flora that they have, putting them more at risk of developing things like C. diff, which is the last thing we want, really. So, Nabeela, thank you so much for the work that you've already done and the work that you're continuing to do with creating these UTI bundles. I think they'll be a really, really helpful resource for people. If anybody wants any assistance with what they need to be requesting on EPR, please feel free to reach out to the infection control team or the pharmacy team, Nabeela.
I'll definitely do my best to help.
Thank you. Any questions at all, please feel free to reach out for us. And if you're interested in joining Nabeela with her UTI bundle work, then please reach out for her. And thank you very much for listening. And we will see you next time with our next podcast edition. Any IPC related issues, please contact us on Gloucester 6122 or Cheltenham 3129. Thanks again, everyone.
Thank you.
Thanks. Bye.